behavioral scientist, and she co-directs WashU Center for Collaborative Care Decisions. Her primary research interests include health communication and shared decision-making, designing and implementing decision tools for patients and clinicians, and a whole lot of other things that at least I ask her about. She also focuses on ways to reduce the burden of healthcare costs, helping people find ways to offset high costs of care through insurance decisions and cost-saving strategies. She works extensively with community and clinical partners to make sure that her research is relevant, practical, and impactful to end users. She earned her BA in psychology from Columbia University in New York and her PhD in clinical psychology from George Washington University in Washington, D.C. It's a pleasure. I've known Mary for a long time, and it's great to hear her talk about her work because it's been a long time since I've heard that too. So welcome. And
thank you. I think I have to hold this. How did you get it to work without holding it? Did you just lean down or you held it? Yeah, I might hold it. I'm a little further back. Thank you so much for coming to the presentation and allowing me to talk about some of the work I've been doing over the years with my lab. I'm going to be talking about multi-level interventions that support health decisions across settings. And I know most of you, but I don't know all of you. And I don't think we've talked a lot about how I started my interest in public health. When I was in New York, I was working on a project as an undergraduate research assistant, helping families learn about asthma and help keep children out of the emergency room when they had chronic asthma. And my role was actually to go into their homes and teach them about behavioral strategies to help reduce their symptoms. And, you know, I looked for data from the time, this was the oldest I could find, and they're a little earlier than that, but it hasn't changed since then. And actually the rates are still about two to 2.5 times the rates of the rest of New York City. And I think there's a lot that I learned from interacting with people one-on-one that led me to go into clinical health psychology, thinking about the ways we can not just work on behavioral strategies and symptom management, but thinking about the larger context in which people live and interact and the environment that they're faced and the social determinants of health. But I really enjoyed getting to know families and getting to hear their experiences that helped me contextualize what I wanted to do and how I wanted to intervene. But my clinical background is what made me focus a lot on health systems and working in the healthcare setting to think about how we could make the care experience just a little bit more user-friendly, patient-friendly, and better align what care people want with the care they got. So this is how I like to conceptualize some of the work I've done from the individual all the way through the policy level. But because of my training and my clinical background, I really focus a lot on the individual and interpersonal aspects of care, supporting care quality and helping people navigate through the system a little bit back towards the organizational community level. And then I'll talk about some work later on improving engagement and research and care delivery. So these are some ongoing projects I have. I'm just going to talk about one or two. The first one I'm going to talk about is about breast reconstruction decisions after mastectomy for breast cancer. Many of you have heard me already talk about health insurance decisions and costs of care, which Deborah mentioned. So I'll just kind of briefly touch on that. And then some work that I have going on about informed consent decisions and best practices. So this is one of the main reasons I got interested in shared decision-making in the healthcare setting. So when I was working one-on-one with people and with clinicians, a lot of people talked about how much is uncertain about their healthcare. Paul Hahn is one of the leading experts on uncertainty communication. And in one of his qualitative studies, this clinician summarized uncertainty as they're practicing. So even when we try to quantify things for patients, they're not always as certain as we would think. And this person described it as more from a science to the art. When we're not certain, we give the patient information, help them make their choice, and make it more of a personalized element of care. Part of you wants to get rid of uncertainty and make a better equation, but you have to kind of embrace it. And this is one of the primary things patients were telling me when I was doing clinical work, that it's not just that they were making decisions in the care encounter, but then they had all of this uncertainty to grapple with outside when they went home, and no way to connect the behaviors that they were asked to engage in and the care they were choosing with some of this information they were getting. How did they make sense of it? How did they integrate it? And this is a big reason I don't think that AI is going to replace clinicians very much. This uncertainty was managed in the relationships they had with their care team. There was also a big push for many, many years. Dartmouth actually led this initiative for people to study care variation based on where people live. And a lot of this project originated to study how we could institutional norms and policies actually impacted the care people got for many elective procedures. So this is one that's about inpatient knee replacement. And I started looking at these maps and realizing that you could almost get the identical map in all different contexts that was really not explained by patient variation. It was really explained by clinician and hospital norms. And when you start digging into the data, people were often not expecting that there were options and that there were alternatives. They were really just going based on what care was offered at the site they were treated. And you can imagine for some things this is okay, but for other things, people had strong preferences that they weren't always being offered. Sometimes it was just not available based on the geographic region, but sometimes it was just because that's the way things were always done. And this is not necessarily the kind of care we want to provide when we're thinking about personalizing care, personalized medicine, and thinking about all of this uncertainty that's managed for people to make decisions that work for them based on their values. And individual preferences matter even when there may be dominant options. So I want to do a brief lottery with everyone in the room. And if you're on Zoom, just think about it in your head. I want you to imagine that you're choosing between these two lotteries. And in the first example, you have a 50-50 chance of either winning $20 or losing $10. In the second example, you have a 50-50 chance of winning $8 or winning nothing. How many people in the room would choose the first lottery? How many people would choose the second lottery? Okay. How many are unsure? Not sure. It's not the Powerball. All right, now you have a different lottery example. So I want you to now think about these two lotteries. The first lottery, you have a 50-50 chance of winning $20,000, so high stakes, but you could also lose $10,000. Or you have a 50-50 chance of either winning $8,000 or winning $0. How many people want lottery A? Deborah is a big risk taker. How about lottery B? Anyone want lottery B? All right. So if you actually ask economists in the first example, lottery A was the more dominant option, but they're roughly equivalent. You know, now that there's all this inflation, $1 isn't that big of a difference. So the way you calculate the value of each lottery from an economic standpoint, you start at the nodes. This is a classic decision tree. I'm going to start at the right, on your right. If you have a 50% chance of winning $20, you multiply 0.5 times 20, you get $10. And then you subtract $10 times 0.5, you get -5. So the expected value for lottery A is $5. If you do the same math for lottery B, 8 times 0.5 is 4, 0 times 0.5 is 0. So the expected value is $4 for lottery B. So those of you who chose lottery A, that's technically the rational choice from an economic standpoint, but some people didn't want to risk losing $10. In lottery, the second example, lottery A actually has a $5,000 expected value and lottery B has a $4,000 expected value. This is a much greater difference. But most of us, I think there was only one person in the room who chose lottery A. We don't really want to risk losing so much. And I use this example a lot with clinical situations because there's some things that patients are just unwilling to trade off. It's too big of a risk, even if the outcomes prefer or lean towards one option from an evidence standpoint. Most people did shared decision-making originally thinking about equipoise, clinical equipoise where there's equal likelihood of outcomes and it's really just about your preferences. The inpatient knee replacement example was one example where maybe you might be in more pain and you want faster relief, but you could also try other alternatives, no major differences. But sometimes there's strong differences and patients still want to prefer a different option because they don't want to take that risk. And we know that risk communication really matters. I could do a whole lecture on risk communication, but just suffice to say that people interpret numbers very differently, and especially risks about their health. So some people think of it like flip of a coin. It's either going to happen to me or it's not. I'm not sure what to pick. Other people think of it more like a real lottery, not the lotteries I gave you, where the probabilities are so small, they think, oh, it's not going to happen to me. We also know that across many different contexts, people want to engage in decisions. So this is a study we just did a few years ago because we were studying anesthesia choices for hip fracture surgery. And a lot of people told us, what does it matter how I fly the airplane if I get people safely to their destination? So if I'm doing surgery with anesthesia, what does it matter what anesthesia option they choose? We said, well, maybe it doesn't matter to people. Let's ask them. And even in this situation, which some people assume this is for older adults who are having pain from a fall, people assumed they would just be comfortable with whatever their clinician wanted. And they actually told us, in many times, they actually preferred a patient-led approach to that decision or a shared decision-making approach, where they communicated with their clinician and got information about options. And this was actually a higher percentage of people that preferred physician-led decision-making compared to other studies I've done where it's around 8 to 10%. So the clinicians were onto something. There were more people in that study than in other situations that wanted a physician-led choice, but it wasn't as high as they thought. So that's the why, a little bit about the why of study what I do. This is a bit about how. You may recognize this implementation model from the PRISM framework. I start by trying to understand people's needs from the individual and the clinical setting, and then look at the best population data we have. So how could we better communicate some of that evidence and explain the evidence we have at the population and make it relevant to the individual? And that's what goes into developing these interventions that can help prepare for future dissemination. So it's not just the individuals and the intervention, but it's also the external environment and the implementation infrastructure. So I'll give a more concrete example of how this looks using this breast reconstruction decision-making example. So this is a project that we've had going on for many, many years now, where this came from patients and from clinicians that said, this is a situation where people are thinking about undergoing mastectomy for breast cancer, and they have many choices. They can choose to either have reconstruction or not when they have a mastectomy. They can choose to have it at the time of their mastectomy, which is immediate reconstruction, or somewhere down the line. And they can choose to have an implant or their own tissue to do the procedure. And at the time, the reason clinicians were really interested in this is they said, the risk of a complication from immediate reconstruction can be about 23%. And for some people, it could be as high as 52%, which is higher than most elective procedures. It was pretty risky. But patients weren't always aware of that. And they also were expecting that the clinicians would then offer something and it would be done. And some people were having up to 19 procedures. That's the high end of the range. That's not good care. That's not what they were expecting. And there were lots of gaps in the communication about what people were learning at the time. Most clinicians were saying, I really only talk a lot about the benefits because that's what I can offer them. I don't want to tell people these potential downsides. I think that maybe will turn them off and people want to feel good about my care. And patients then, not surprisingly, didn't really understand that there were these major risks of complications and major risks of especially from immediate reconstruction. So we asked patients what they thought, and they said, you're right. People weren't always telling me I had an option. There was not a lot of discussion about this, and that people weren't getting into the detail that they wanted to hear. And this was more pronounced among older people and people of color that said they were really not finding the information they wanted to help them make their choices. And clinicians actually admitted to us that they even used these words, I brush over it a little bit because they didn't like to explain at the time that this was something that could go wrong. They were trying to instill optimism and they were trying to promote what they could offer to patients. So this was nationally, this wasn't just in one site. People were telling us across the board, this is a hard thing to talk about. And the AHRQ has this nice decision support guidance that talks about finding the ways to develop an intervention that makes it useful at the point of care, where we need to figure out first what the right information is to provide people, which to us was education about these options and interactive learning with quotes and photos. This is what people told us they wanted to hear. But we also have to figure out the right people and including this personalized estimate, because a range of 5 to 52% is pretty big. You might make a different decision if your risk of complications is 5% compared to 50%. People also told us they wanted to see more representative examples that looked like them and had more commonalities to the people that were actually being treated. And they were unsure what the right format of the tool would be if they wanted to get some information. They didn't know if they wanted something that was digital or static. Clinicians often like static information they could use right away without having to go through a process of personalizing things. The patients often wanted to play around with the data and know what it was like for them. Most people talked about EHR integration. I'm going to get into that a little about the challenges there, but if bare minimum, if it's interactive, it needs to be on the web. And getting things to patients at the right time when they have a cancer diagnosis is also Patients get diagnosed at all different ways. Some people get phone calls, some people get patient portal results, some people find out at the time that they're meeting their clinician. So trying to meet information to people at the point of care is challenging. So I'll tell you how we addressed it first. We started out by doing a single site study where we developed an intervention that was web-based, not in the EHR yet, to make sure we could really do this well and we could get people to follow the information and it would speak to their needs. Patients and clinicians supported using it. They said it was really good at gathering and pulling my thoughts together in one place, that it would help them at the time when they're getting a diagnosis where their brain is all over the place. And clinicians told us, this was really addressing their need that patients don't always know when they're high risk, and that if they went into the consultation already knowing that, that would be good. When we did our pilot RCT, we did find that people that got our tool, which we called Breast Choice, it's for Breast Reconstruction Education and Support Tool, they knew more about reconstruction and they felt more activated to participate in that conversation. And clinicians wanted to know, is this going to take away more time from our consultation? And it really didn't. It really only took about the same amount of time, which was pretty long to begin with. They were getting a lot of information. It was about 30-minute consultations. The one thing they did say was that we don't always know who's using this because they're not always bringing us this nice summary that the tool created for them. You can't really put that burden on the patient. They still wanted something EHR integrated, which is a big lift to create. But we use this data to try to think about how we can make it better for people. At the same time, colleagues that were working on this personalized risk prediction model updated this model using a lot of epidemiological and claims data, over 17,000 people with then a longer follow-up period in 2020. It was data collection were completed for this in 2019. Our tool was going live in February 2020, which I'll get to in a bit. But there were lots of interesting and unexpected risk factors that went into their risk prediction model that clinicians weren't always using to communicate risk to patients at that moment. So this was also helpful as we built in a more interactive tool when we refined it in 2020. So this is what it looked like. People also told us when they wanted something to be used clinically, they wanted it to match the look and feel of things they were already getting. So this was matching Siteman, which was one of the big sites of our implementation. And it kind of integrated more seamlessly into tools and materials they were already using at their care. It had much more white space and user-friendly layouts and design, so people could better compare their options. This is a big fundamental principle of shared decision-making, is making sure you could easily compare your choices and understand what the pros and cons are for you. And this is what it looked like EHR integrated. So this is the clinician view. I would not love to practice as a clinician with Epic. I think this is really hard to find. We asked people where to find this and where would you like us to put this? They told us where to put it and they still had a hard time finding it. One of the things is for our own protection as patients, you cannot just put something in the EHR without having extra layers of protection and steps because it becomes your permanent record. So first, clinicians had to find this, then they had to click on this summary, and then they had to accept the summary once they saw it. So it was like a couple of steps of EHR integration. This was the best we could do. And this was pretty sophisticated design, also happening at the same time that the informatics teams were doing a lot of COVID modeling, which was an unexpected impact in 2020. But nonetheless, they did it. And clinicians said, if you tell us where it is, we'll open it. We'll get to that in a minute. Because this was EHR integrated for the clinician, for the patients, they had fancy graphics and a nice layout. For the clinicians, they saw this kind of text-based summary, but it still was more similar to notes that they saw. And this is just an example, but they would see a summary of who the patient was, what their risk factors were, what their preferences were when they went through the tool, and then questions that they had. So this was really designed to facilitate more of a conversation, whereas the first study was much more patient-led. And we wanted it to be much more about the conversation people were having. So this was the most interesting finding from our multi-site randomized trial, that we actually found across 2 sites, we still had patients reporting higher knowledge about their breast reconstruction risks, but also the percentage of high-risk patients, which we defined as twice the average risk, were less likely to choose a high-risk option for their care. We only had 29 people that were defined as high risk. This is way too small to make huge inferences, but A high-risk option would be immediate reconstruction when that's the highest likelihood of having some major complication requiring additional surgery, additional procedures, because they're still healing from mastectomy. And when they have these other risks associated with it, this was where clinicians were often struggling to counsel patients about what that was like. It doesn't mean that they can't choose it, but they should be prepared to know what to expect. So this was encouraging that we thought perhaps we're doing something more than just activating patients in terms of knowledge, but they might actually be impacting their choices. But not all clinicians used it. So that was one other downside, that we had to do this at the time people were already stressed, already busy with lots of other things on their plate, including everything else going on in 2020. And there were still several people who were just not opening the EHR at all. When they saw the patient, they would use a resident or a nurse to check them in, so they never got the summary. And then a couple other people that just had different workflows and were not as motivated to use it. It did take a couple extra steps. So this was at site 1. And at site 2, they had this unexpected lag in when they could start using the EHR, because their team was doing COVID modeling and they couldn't get it integrated yet. So they started out on paper. And unfortunately, for any informatics people in the room, they loved the paper. And so they wanted to print it out and have it, hold on to it and use it, which made it a little harder. Once we did go to the EHR version, they dismissed the best practice alert right away. It just popped up and they just started clicking out of it. They weren't already being trained. So we had to retrain, because at the time we trained them, they were starting out with paper. And then at the end of the program, we still don't know why. There were a few patients that just had blank summaries. So it didn't work as smoothly. And I'm pointing this out because everybody's really big on EHR integrated tools, and I think they have their benefits. It's really great to get information to people at the point of care to facilitate these conversations and to get personalized data, but it doesn't always work as intended. The next thing that we did after we learned this, which we just finished wrapping up that data 2 years ago, was we listened to our follow-up from our patients who said, I loved using this, but I also want to be able to share it with people outside of the clinical context. And some people weren't even using the portal or the EHR and wanted to be able to give a link to a family member or friend. So we also wanted to think about ways we could make this more accessible for people and better and more shareable. So this was the next study, which is now being led by a colleague at UNC, Clara Lee, who's a plastic reconstructive surgeon, is to actually take the tool and now make it available through social media and online communities. So we can see if we can get more access to people who are preparing to meet with clinical teams. We already heard from people that they're using the internet first for lots of health information, and that they want to use social media in particular to access this information. But a lot of what people get on social media is not always evidence-based and not always linked to best data. So this was the most recent project. Now it's being created so it could look a little bit more modern and better able to be integrated into smartphones, tablets, other things that people are using on the go, not just in their clinical setting. So that's the first study I wanted to go into. There's several different community and clinical partners involved in this team. And there's also many different people that you might recognize in this room, in other spaces, and from our informatics teams as well, that are either currently or historically have been involved in putting this all together. I mentioned this just because none of this work is done in individual labs, even though I'm presenting on it as work that our team has been doing. It's really collaborative across many different settings and sites. It also takes several different proposals to get some of this going in terms of all of the data, all of the design, all of the integration into the EHR, and then even be able to make it accessible to larger communities. That's just one example of an individual and interpersonal aspect of care that has facilitated some of this work on decision-making. I can't go through the whole talk without talking about cost just a little. I know people have heard me talk about it a lot, but I just want to mention it very briefly that cost is so important to people's choices, and we often ignore it and don't talk about it because it's a taboo topic. And we know costs are rising in the US. They're also rising globally, but we have unique challenges with our health insurance system. And patients universally tell us they want to know what their care is going to cost, and especially when they're making decisions about it, because it is one factor. I've had grant reviewers say this: how do we know what patients are going to have to pay? How could we mandate clinicians talk about this? This is not everyone's job. If it's not anyone's job, whose job is it? I think we have to start the process when we're making choices. And actually, there are ways that talking about cost can help lower costs, but even when they can't, it helps people prepare for what to expect. So this is just one study that we did where we just wanted to see if it does impact what people talk about. So this wasn't the main goal of the study. This was a small side project within it. But just being interested in cost, I wanted to take a look at whether when we have a cost prompt in a decision grid that compares options, do people actually talk about it? Do they use it? And if we don't have a cost prompt, do people actually talk about it? So we actually had audio recorded encounters where we examined this, and we found that when we did have a cost prompt, surgeons initiated cost discussions about 67% of the time. And people thought surgeons would not want to talk about costs, and they did. And they actually talked about it in the context of comparing treatments. So not just about this is what your test will cost, but actually this is the relative cost of this versus that. And that in the group that didn't have a cost prompt, patients did bring it up, but they didn't bring it up as much as they probably wanted to. And it was really asking questions about how much their care would cost. So this is the kind of cost I'm mentioning. It doesn't have to be precise. It could be relative. So if you look at the second row, this is just a visual about how costs compare in one of the pieces of a prostate cancer tool. And you can just compare dollar signs, just like you do at a restaurant if you're choosing a restaurant and you want to know approximately what things cost when you're going out. So this is for care. If you don't know the precise estimates, you can do this. Or you can even do something like this, where you just list resources for people to find out about it. Even these brief interventions that prompt people to ask make a difference. Okay, I'm going to briefly talk about one last project and then have plenty of time to have conversation for questions. And you'll hear some of this if you're coming to our visual consent workshop, which has been advertised. But I want to mention another project that came out of things I was working on that involved informed consent. So many of us remember when we all had to shift virtually to going to recruitment for research on Zoom and on the phone. In the past, when we were working in clinical settings, we could meet people face to face and we could say, this is what our study's about, this is what we're doing. But all of a sudden, March, April 2020, we're showing people on a screen this informed consent document that was about 12 pages long. And Krista Cooksey, who's in the room, led this work and looked at how long our tools were, even for an exempt project, which is a survey that doesn't have any PHI, no protected health information. It was still 5 pages for her and other people on the team to read out loud before they would even be able to do the study. And then there was another study that was an intervention study that was 8 pages. And we actually had quotes from participants that misunderstood major parts of the study that said, I thought you told me I was just answering a survey, but now you're telling me you're going to tell people in my family I have cancer. They don't all know about that. I'm not sure if I want that. And after looking at this disclosures that you've said you'd share with others, I've decided not to participate. And this study had no information about disclosure. And when we asked them about what they were concerned with, we actually went back and looked. We had 7 different places where we mentioned this potential breach of confidentiality from a survey. There were 7 spots of our consent form that had that. We got really lucky at the time. The head of our IRB was also a cancer trialist herself and said, what could we do? How could we make this better? And we had this nice conversation with her where she suggested that we use the key information page. This is a new rule under the 2018 Common Rule that suggested that we have this concise and that actually mandated for federally funded studies, a concise and focused summary page that gives the most important study information. And she said that, there's a mandate that we do this, but there's no guidance on how, and show us what you can do. And she said, if you're clear on the first page, you don't have to repeat yourself later, especially for an exempt study, which is just a survey or interview. So she went to us and said, what can you do? And then Siteman Cancer Center said, we want to do this too. We want to do this for all of our studies. How could we do this and just implement it? And we said, well, we want to study it. We want to make sure we're doing it well. We're researchers. And they said, well, why don't you do both? So we look to our colleagues that study implementation science, and Alex Ramsey, Enola Proctor, Sarah Malone, who's maybe on Zoom, Bill Powderly, they published this nice framework that we use called the DART framework, which is about designing for accelerated translation. And we use that to be able to adapt our interventions and test what we were doing at the same time that the IRB and the Cancer Center were really gung-ho about just doing it and implementing it. So I hope that I did this justice because many of them are probably here or listening. But this is just what we did. We went to them. We tried to follow this procedure. So we first identified these 4 pilot trials to test this out. Many people were willing. Almost everybody was like, if you could do this and get it through the IRB, we're on board. But we created and supported these surveys for people who were using the visual that measured specific trial outcomes as well as broad outcomes about implementation. And then we also surveyed the staff and PIs to make sure it wasn't burdensome for them. We were surprised by how high these numbers were. The weighted mean knowledge score was 88%. So this was hard details about their trial and that they understood just by using their visual key information page. And almost everybody said they approved it. And the people who were the most conflicted, the 10% that were conflicted, they were mostly in the phase 1 cancer trials, which was really hard to decide what to do. And the research staff actually told us it's going to be easier not only for the patient, but also the study coordinators who are helping consent the patient, and not having to look through this document that feels like a contract would be much more interactive. So this was an IRB member who was on board as well. We also did lots of qualitative work to make sure we were finding the right format. And I'm going to show you what some of them looked like with people all the way from research team members through community partners to PIs and IRBs. So we started out in the top, your left, where we actually just created this on our own. It doesn't look fancy. It's just done in PowerPoint. And we started there because that's what we could do. We thought it looked good, but when we went to a graphic designer, they were like, oh, the icons, you got to put them all together. You have to match the colors. It looks too cartoonish. So they helped us kind of organize this. So then the left comes on them next. People said, in the community, I like the icons, but I'm not sure what they look like. I think they look like road signs in Germany. Like I'm supposed to know what they mean, but I don't actually know. And they thought it was a little too institutional. So we went back to them and said, okay, well, this is great. We like it. It looks pretty. So then we tested this version, which was 1 to 2 colors. It was integrated with the text, no more than 2 icons per box. And a PI told us, I like this one, I would use it, but people are expecting a form, and forms don't usually come in this landscape orientation. And I'm thinking of legal documents and things that are more official, and you just have to make it better oriented to fit within our IRB contracts and guidance. So we also tried 2 other ones that were just integrated with our standard forms with just a little bit of color and some images in the regular text. We thought the IRB would love that. And they said, if you're going to do something different, go radical. Like, okay. And then we tried this roadmap. And so this is what we settled on. This is our final version. This is what our IRB is now allowing people to use, even without having to come through our lab for a long time, maybe 6 months or so. They had to come to me first and say they were part of our pilot. And now they're trained to review these and use them as key information for any study. And if you cover that, things about costs and benefits and risks, and you don't have anything more to add, you don't have PHI, this could be it. This could be your consent form. So we have a toolkit as well, and we have these things on the side that help people figure out how to do this formatting wise. Eliana was really huge in helping get this together, and also be able to save it. So that goes away when you save it and you insert it into the IRB's document. And there's a whole icon library of many different ones you can choose from, hopefully ones that meet your study needs. But the icons aren't the most important thing, which we'll get to in a second either. So whatever you use is better than what's there, and you can choose just a couple that match your needs. So we've done this in 36 that we've piloted, and there may be more that we don't know about. And there's a study at NCI doing this. There's a couple sites through the CTSA network at University of Utah and University of North Carolina using it. And the one thing a research staff member told us was that the only main concern they had was that they wanted to make sure the IRB reviewers were on board and trained, and making sure that they would be putting something together to understand how to do it. So that's my plug for 2 weeks from now. Come to our training, because we're actually going to be walking through labs that want to do this, and we'll do hands-on guidance on how to actually put these together, how to get them reviewed. We'll have IRB members talking about how they feel about it, how they contributed to it. You can register, or you could probably show up. We won't kick you out. And this is just the small study team that's done this, but there's many more people, including at Siteman, including someone at the PRMC, the Protocol Review Monitoring Committee, who I consider a super user, because she uses them and I barely have to edit them at all. She just sends them right on, and they're amazing. So I think it's easy to do once you get the hang of it. And Siteman has been a huge, huge supporter of this work, and I'm really grateful for them. And hopefully the HRQ continues to be. That's remains to be seen next year. This is my center website also, if you want to do any collaborative projects. I have so many more I didn't talk about, but I'd love to work with people, especially new colleagues that I don't know, that I haven't worked with yet. And this is where to find me. Thank you. Oh, I turned that off and now I guess I'll go back to here. You don't need to see. I mean, that's fine. That's just my slide background. Hi, Ross. Sure.
Yeah, very, thank you. Thank you. That was really great. This interesting work woven together very well. I think I have a two-part question. One, of the clinical decision tools you've worked on or others related to your work, what would you prioritize toward the top on the list that you'd like clinicians to do because they can't do everything? And then what would it take for either small P or big P policy to get this done?
Yeah, that's a tough question because, oh, I don't know if this is still on. Yeah. So I'll just start with the breast reconstruction one. The clinicians that were part of the study still want to use it. It was a big informatics lift. And when you want to keep something going in the EHR, it costs a lot of money and it costs a lot of time and resources, even though it was already built. And so that's another big reason why we're doing this outside of the EHR now. I love working with informatics teams and in the EHR, but I just think we're not there yet in terms of sustainability. So the first thing I would say is to get something used from a policy standpoint, I would start outside. And also people are on smartphones more and they don't necessarily want to log into MyChart or Epic and use their phone and access these. And you could make them more user-friendly that way. I would say for a clinician policy, it's really a lot about incentives. And not just financial incentives, also just the seeing the benefits to patients, seeing how people respond and engage and follow through on their care when they're engaged in the process. And then the last piece is if you could link to epidemiological data and the best practices in evidence, that also helps with buy-in because then people see the value. It's better than what people find when they just Google something. It's better to get the data connected and be able to update it and show that it's coming from a reputable source. So it's not just people thinking through their options without the evidence that clinicians are using from journals. So then it actually helps clinicians because they don't need to summarize the data themselves. It's there, you've vetted it, and you got them on board.
Well, have people, have Roger's opinion leaders in diffusion theory, have people experimented with different opinion leaders that clinicians might look up to and know about to see if that moves the needle on any of this?
So I would say the opinion leaders are really the guideline developers. So there's a lot of guidelines that mandate shared decision-making for certain procedures and it's growing. And I think that the challenge when you have just opinion leaders saying it's important is how do you get people to do it? So I think we're seeing a generational shift that many more residents and early career clinicians are using this more standardly in their practice. They've had that training. I had a resident in my class once tell me, I did share decision making. I used this tool, and then the attending came in and just said, "Let's just do surgery," and they were like, "Oh, I just undid everything I just did." But it was more just that the guideline developers help, and then I think the opinion leaders, maybe we need to shift towards them being in more power and more support for the next team that they're training, because a lot is hierarchical in medicine. So if attendings aren't on board, I mean, the people I've worked with have always been big supporters. But I have a biased sample of people that have said, hey, let's do a project together. So I know it's not universal yet.
I have a question about, I forgot, is it 5 R's?
Oh yeah, the 5 rights framework, yeah.
So the question is how generalized that framework? It's specific to that tool, or is that a framework for other tools, any tools?
Yeah, I think it was designed to be a framework for decision tools specifically because there's so many aspects you need to consider when you're designing a tool that's, especially if it's going to be used more in the context of a clinical setting. But I think it could apply even outside to policy, to community decisions prior to getting to a clinic. I think there's a lot of ways you can apply it. It's really how I just like to think about the steps I need to go through to consider how is this going to work best in the setting I'm trying to implement. And you have to make decisions along the way. I mean, it doesn't just get created based on what we think is going to work. We really have to uncover in formative work each step of the process. What can we do to make that part of care better? So the EHR integration is a big example. That was really something people were just pushing for many years. And I think the pendulum is swinging back to these simpler designs that can be used right away, even on paper. But even if it's not on paper and it's just a PDF that could be put into the EHR more easily, there's been a bit of a shift because people find that you actually talk about things that patients care about when you can just focus together on one piece as opposed to this whole long process. Hey, Susie.
So I'm glad to see that you didn't have any extra time that it took to use shared decision making. But I'm wondering, in an effort to get even more efficient in how we practice, have you looked at AI to help guide some of this shared decision making with patients, maybe before they come in for a consultation? Or is someone doing that? Just curious.
Yeah, that's a great point. I haven't personally used AI yet, although I have used it to help summarize some of the content that I'm putting in. There are people who are using AI. Actually, Epic has an AI chatbot called Emmy that's associated with it now. And some people are using that to help patients prepare. There's mixed information at this time about how much they trust those AI chatbots. AI, I think, is really good at summarizing data to the point where it was last updated, but a lot of clinical medicine moves so quickly that it doesn't always have the most recent data at this moment in time. But I think there's real value and use in the future of using AI. I'm not afraid of it. I think it's actually going to be really useful. I just don't think it's going to replace a lot of this discussion, but it could help prepare people for what to expect at the moment.
Thanks, Mary. This is great. I wanted to ask you about your consent form and the IRB that you've been working on. We currently have a multi-site trial that uses Smart IRB, which I have some arguments with that name.
Yes.
Community study.
Yeah.
It's just the challenges are immense for the sites. They drop out because especially those resource sites can't do it. And even if they can, the families, which these are families and communities, wonder why they're signing a 10-page document.
Yes.
They don't know what they're signing. You said that you've been testing this in several sites and picked it up. Is there any use of this in multi-site trials, or has that been moved forward, or do you see that happening outside the clinical setting? Because I think that really has promise for getting public health populations involved in research, because right now I think we put a barrier where we keep a lot of the really important populations away because they think they're signing their life away, if it even gets to them, because there's so many hoops people have to go through.
Yeah, I totally agree. Yes, NCI is actually doing one on a community trial, and they're using our visual consent form. If you describe it as key information, that is a mandate for all IRBs to be using for federally funded studies. And so they're familiar with that language. One of the things we learned is we can't call it a flyer. We can't call it a recruitment material. We can't put it in miscellaneous attachments. We can't call it something that's not consent because it's being used as consent. But if you call it key information, there is no guidance on what counts as key information or how to, well, no, there is guidance on what counts, on how to display it. So we have not had any major barriers at these other sites, but we have had to do a lot of networking and connecting with their IRBs to get it used there. We've also had one study in particular where they had a multi-site study and they used the Smart IRB, SIRB, I'll call it. But I agree with you. It's not always that straightforward. And they just had a slightly different version of their consent at each site, which is true anyway. Most sites still manage their own individual policies, even if one site's overseeing the risk. So you could start there too. In all of the time I've been doing this with just a few years of getting data, I've had just one site say, absolutely not. That's just not something we're going to do. We have our own policy. It's legal related. But most of the sites are pretty interested in it because they see it as a benefit to their participants, just like you said, especially in the community. And of those 36 trials, actually, many of them aren't just clinical. Some of them are community sites that are doing work not in our setting and just using an e-consent. So they're not even meeting face to face. We have incorporated into REDCap and Qualtrics and things like that. So. Joe?
Thanks, Mary. That was really interesting, and I want to kind of go back to something you said at the beginning about risk communication, and you said that you could give a whole lecture on that.
Yeah.
And when is that scheduled?
Actually, I just got my new course in public health and society approved, so it's going to be in the spring. But I used to teach a class at the med school, and that was 2 of our lectures actually on risk communication to patients and then to the public.
This is something that I feel like going not just in your work, but just kind of generally in public health and medicine. I feel like we've lost that game, especially over the last probably 15 to 20 years. And I think it's being, if not eviscerated, I think it's being eliminated from a lot of curricula. And I'd like to hear from your opinion how important that skill is, and how important or how much easier it would make your work in working with the clinicians if they had that skill.
Yeah, it's a really great point. I think many people were trained to use something that's not transparent for people, the 1 in N format of 1 in 10, 1 in 20, 1 in 30. That was just part of medicine for many years. And that's really confusing for people to have to do the math, which is bigger, which is smaller. What does that mean? So I could just give one takeaway to anybody, it's just to keep the same denominator. It's just much simpler to be able to compare things and to show a picture, show a graph. Those are 2 things I often say. I think the biggest thing with risk communication in the clinical context and probably in the public health context is that it's not just the number, it's also how we feel about the number. We might feel very differently, just like in the lottery example. So it's both understanding the information, but also how we make sense of it to make those choices. And we probably want to use different strategies based on our goal of communication. Matt could talk about this a lot and did in a couple of his papers on narratives where you don't use a lot of numbers, and in risk communication where we're trying to be persuasive and get people to change behavior that we know is better for their health, versus what I do is much more about transparency in terms of making choices about uncertain decisions. So I would say to your question about how we could do it better, I think in medical school, they are trying to do it better. At our medical school, they actually now have a module on risk communication in their practice of medicine class, which is for all first years take that. But I think nationally, there's still a lot of gaps in broader science communication, as we've seen in recent years. Ellen Peters also has a great center at Oregon where she's doing a lot of this work now on science communication more broadly, where she does a lot on numbers and risk communication. So I look there when I need to find out today's version of what we do based on our goals.
Thank you very much, Meredith.